So we're going to move forward. The next topic is urologic emergencies, and we've invited Dr. Ken Neppel, who is an assistant professor at the University of Iowa. I've known Ken for not quite as long as Dr. Griebling. I've known Ken probably about 15 years now. He is one of the rising stars in urology, and I think you're really going to enjoy some of the urologic emergencies that you probably may see in a primary care setting. Ken?
All right, thanks, Dr. Winfield. I appreciate that introduction. And I think Matt and Tomas have set a very high standard for the talks here. I think this was aimed towards primary care providers, but I know there have been changes just in my practice and what I've seen thus far, so I'll try to keep up with that standard. Just to follow up a little bit on Dr. Griebling's talk, just as a quick side, I think the other thing to think about in those overactive bladder patients, as he alluded to with checking a urinalysis, is the thought of possible carcinoma in situ. I'm actually a urologic oncologist by training, and so we will see that on occasion people are treated for refractory voiding symptoms, and people don't think about that. So keep that in mind as far as men or women with refractory symptoms could potentially have carcinoma in situ, especially in the setting of gross hematuria. So commend everyone for making the trip here this morning. I know it's a Saturday and very nice weather outside. I'm from Iowa. We actually, within the last week, had 4.5 inches of snow. So that brings another meaning to April showers. In that case, not too good for your Mayflowers. So I appreciate the invitation. And so Dr. Winfield had asked me to talk about urologic emergencies. So the first thing I did was, contacted my 18 residents that I work with there at the university and said, okay, well, what are the 3 topics that we should talk about, and had each of them tell me what they thought was going to be important. So topic number 1 here, acute scrotal pain, and number 2, obstructing ureteral stone, basically came up in every single one of their suggestions. The third one I think is potentially relevant also. And so we'll go into the first 2 in more detail, the last one in not as much detail. In interest of disclosure, I will, during the ureteral stone discussion and the priapism discussion, talk about off-label usage of medications not FDA approved and not actually FDA evaluated, but widely used in clinical practice. So just as a note there. So we'll talk first with acute scrotal pain. Based on the pretest question, the first thing that should pop into everyone's mind is clearly spermatic cord torsion or testicular torsion, whichever way you'd like to refer to that. Of note, this is very important in practice and potentially has medical legal implications. And so with that in mind, there was actually a study looking at in pediatric population causes of lawsuits. Testicular torsion was the 3rd most common cause of lawsuits in boys age 12 to 17. So it's important to keep that in mind. And notably, a number of those cases, this is from a series in New Jersey that went to court, ended up settling out of court. But in the situation where cases actually went to court, they were actually the vast majority in favor of the defendant. So there are people that are potentially making the right decisions, but this is really an area that I think it's important to focus some attention on with respect to that. And so when we look at a patient who presents with acute scrotal pain, things to think about. I'll focus here primarily on patient just because of time limitations. As an aside, I would mention
that the adult, this also occurs in that study I talked about with the lawsuits. The median age was actually 26. So we see this on occasion in adult patients. Clearly in adults, epididymitis is going to be the predominant diagnosis. And things to keep in mind in those patients, younger patients
tends to be sexually transmitted infections. Older patients tends to be urinary tract infections. But actually, based on my anecdotal experience, the most common scenario is probably finding neither of those two and just inflammation by itself. But for those patients, if you're looking in the adult population treating epididymitis, if you Google CDC recommendations epididymitis, you'll actually come up with a regimen at both empirically treating for possible sexually transmitted infection and also considerations for urinary tract infection treatment. So I always tell our residents, you don't have to know everything, you just have to know how to find everything. So rather than go in detail into those recommendations, just something to think about. So things you want to think about. Clearly, these patients are patients that you want to evaluate in a prompt manner and triage in a quick and timely fashion if they present to your clinic or to the ER. The main concern is with testicular viability. If the spermatic cord is twisted and basically if you've clamped the blood supply to the testicle, there's potential issues with viability if that isn't addressed. So obviously consider diagnosis of testicular torsion. We'll go into the details about these, but I think one of the main points is that within any of these diagnoses, there is a significant amount of variability within how those patients will present in the variety of symptoms. And then across the diagnoses, there's also a lot of overlap. So the main take-home point would be if you're going to look for a absolute indicator of something or a pathognomonic finding, you're just simply not going to find it clinically. I think this is a measure of looking at good judgment in evaluating these patients and having a high threshold for potentially taking the patient to the operating room with the idea that it may end up not finding a testicular torsion. The other things to keep in mind, primary care providers probably don't hear much about, but there's an appendix testis, which is a small 2 to 3 millimeter structure that sits on the superior pole of the testicle, similar to the bowel-related appendix. It has no known function, but it on occasion can twist off and present with pain also. Other things like incarcerated hernia clearly could present with scrotal pain. Epididymitis we'll talk about in more detail. Other things to consider as you get an older teenage patient or a patient in their lower 20s is clearly the presence potentially of a testicular tumor. And from the oncology standpoint, I think the other statement to make with respect to possible tumors is when you think you're seeing any patient, a young male with abdominal pain, I think you should include testicular cancer on your differential and always do a scrotal exam in those patients. I think if you get into the habit of that, that's clearly at some point going to help patients. I know I've seen patients with testicular mass go to surgery for appendicitis and have a negative appendix. I've seen a workup of abdominal masses that turned out to be metastatic retroperitoneal lymph nodes from a very concerning testicular mass. So one thing to always keep in mind and clearly evaluate for. Other things could also be radiated down to the groin region, especially appendicitis or ureteral stones. I actually had a patient a couple weeks ago had been in and out of 3 different ERs for evaluation of urinary symptoms and presumed to have prostatitis. Well, he'd also had some hematuria with that. We did a CT scan. He had a 9 millimeter stone in his ureter. And so you want to think about other things like that. So what about what actually is causing these patients to present? If you look at the literature, it's pretty scattered because nobody's been able to evaluate this in a really systematic, prospective manner. But the general trend, if you look at this series from Chuck Hawtrey, who was at my institution, or other series, there tends to be a trend that in clinically evaluated patients, epididymitis does actually seem to be the most common diagnosis, with testicular torsion being a little bit less common and maybe even less common than torsion of the appendix testis. Just to try to put this in a little bit of framework, I looked at the incidence rate of testicular torsion in males from the age of 10 to 20. It's about 6.8 per 100,000 person years. So to put that in perspective with other things, if you look, did a Google search of that, and if you look at the rate of bacterial meningitis in California in children between the newborn age and 2 years, it's about the same rate. If you look in Iowa at the rate of unintended death from falls, it's about the same rate. So things that are relatively uncommon, but clearly we think about this a lot. One of the factors to potentially differentiate these is if you look at the age of presentation. In my mind, I try to break it down into a perinatal period, toddlers, and then at the time of puberty or afterwards. An infant presents with acute, scrotal pain that's noted on exam or swelling. Most commonly, that's going to be a torsion. In the newborn, the tunica vaginalis surrounds the testicle. That's not yet fused. So you can get a twisting that happens of that whole structure outside that vaginalis. We call that extravaginal torsion. And so that can happen in utero or very soon in the newborn period. Very, very uncommon, though, and unless you're a pediatrician, very unlikely to see that. In the toddler population, got a couple of those running around at home, you want to think more commonly of torsion of the appendix testis. Epididymitis in a toddler is very, very uncommon. Torsion in a toddler is pretty uncommon. So just one thing to keep in mind. And then at the time of puberty or afterwards, epididymitis is going to be the most common, but that's also the population that's going to be the most frequent with respect to torsion. However, when I talk to our residents, talk to them what I call the any problem. So any of these problems can occur at any age. So unfortunately, you always have to keep an index of suspicion, especially for that atypical patient with an uncommon presentation. If you look at patients that are taken to surgery, so keep in mind that epididymitis is treated non-surgically and torsion of the appendix testis is treated conservatively if it's pretty well known that that's the case. So of patients that were treated surgically, keep in mind this is a urologist in most cases or a general surgeon who thought this patient had torsion. They take the patient to the operating room. Actually, torsion of the appendix testis in several surgical series has been shown to be the most common. And then testicular torsion number 2, epididymitis probably number 3 on that list. So without being able to know exactly what are things that we can help to kind of make incremental changes in what we think the pre-test probability is of potentially having testicular torsion. If you look at prior history, most of these series will report about 30 to 50% of these kids will come in with prior episodes of pain. People will talk about potentially intermittent testicular torsion, which I'll tell you is a very difficult diagnosis to make. If you look at onset, a real sudden and acute onset of severe pain is probably going to increase your potential likelihood that you have torsion versus epididymitis. Sometimes may present much later. Those kids may go around with symptoms for a day or two before their parents get concerned enough about that to prompt evaluation. But again, if you look at some of the published series, about 50% of epididymitis, 20 to 50% can actually present, suddenly, with prompt evaluation, potentially slightly more vigilant parents. If you look at the severity of the pain, that may be an indicator. If you look at urinary symptoms, if a child's got a urine that's suspicious or they're having a lot of frequency urgency, that may be a child that's more likely to have a urinary tract infection. There are some, without getting into details, but there's some congenital anomalies of the urinary tract that can actually predispose to epididymitis. So some kids will end up finding in this way. You can actually have an ectopic ureter that instead of being inserted into the bladder itself is actually inserted into the epididymis. So that's a rare, if you hear hoof feet, think horses, not zebras. So there's a zebra for you to think about down the road. One important distinction I would make that I learned from our pediatric urologist in training is the presence of nausea and vomiting. So again, won't be a universally predictive measure, but the vast majority of kids with torsion are going to have nausea and typically with some vomiting and just not feel real well, which makes sense if you think about there's a ischemic testicle there in the scrotum. And so sometimes I'll use a cheeseburger question. You ask them if they'd be willing to eat a cheeseburger, just like we sometimes use for appendicitis. And kids that otherwise feel fine, but they just have, some scrotal pain may be more likely to have epididymitis, while those with real severe associated nausea and vomiting may be more likely to have some torsion. So evaluation, clearly physical exam is going to be important here. You look for the amount of the swelling, amount of tenderness. With torsion, the cord can twist and pull the testicle up higher, so you get a higher lie of that testicle. Some of the testicles involved, and even the contralateral testicle, can have what's called a bell clapper deformity. That tunica vaginalis that we talked about that wraps around the testicle should envelop the epididymis. In rare cases, it doesn't actually cover that whole area, so you have a more freely floating testicle. One of the problems is that in autopsy series, that abnormality is noted in about 12% of people. So clearly the rate of testicular torsion is much lower than the actual presence of that anatomic abnormality, but something to think about. You can look at the cremasteric reflex, so you brush the inner portion of the thigh. That should cause a visible retraction of the testicle into a higher portion of the scrotum. If you use that, that's actually a relatively effective measure. Keep in mind that there was a prospective evaluation of that just in normal kids, and less than 2 years of age, most kids don't have a cremasteric reflex. In kids over 2 years of age, the majority, 80 to 90%, did, but again, not absolute. Blue dot sign is actually what we call a blue discoloration of the appendix testis when it twists. So if you see a small blue dot, the superior portion of the testicle, kids in not very much pain, and not a real marked amount of swelling, you may be able to get an indication from that. People have looked at ultrasound to try to look specifically at that area, but what we're talking about is so small at 2 to 3 millimeters, not super effective to look at. Frayne was a urologist 30, 40 years ago. He had reported the sign that if you lift the testicle, you may get some decrease in the amount of pain with epididymitis versus in testicular torsion. If you lift the testicle, you will get screaming and angry parents. Not super sensitive, but at least something to think about in your evaluation. So look at a urine in a culture. I think in most cases it's probably reasonable to consult a urologist if you're not absolutely sure. And these are kids that you want to be right on. And then we'll talk about what role ultrasound plays in that evaluation. So when you look at patients, when do we do an ultrasound? So in patients where the diagnosis is uncertain and in patients that you're not going to delay their treatment. So I think in patients where you're pretty certain that they may have torsion, the right answer is to go directly to the operating room. We'll talk a little bit about timing of that. But you clearly would rather go to the operating room, have a negative exploration, than miss a torsion, have that present later as a dead testicle. And clearly you want to have a radiologist or a tech that's available. But still the paradigm used to be take all these kids to the operating room. That's clearly fallen out of favor to where it's now take the patients that you're suspicious or indeterminate to the operating room with using the ultrasound to help guide your decision making. Why is an ultrasound perfect? In patients that have torsion at exploration, the sensitivity has been reported as up to 90%. However, what you get concerned about is some of those studies have ranged down to the 60% range. So if you're getting closer to the chance of flipping a coin about finding a torsion based on the ultrasound, then you get a little concerned. So I think you just want to use this as part of your clinical picture. Even if your radiologist says that I see blood flow, don't take that as an absolute that there's no torsion. One of the reasons you could have what has been described as potentially a partial torsion, you may still see some flow that gets through. Early on, the thought is that with the spermatic cord twisting, the veins occlude first, and then with the back pressure, you get no inflow from the testicle, so at least from the testicular artery. So at least in theory, if you're early enough, you may not see a problem with your arterial waveform. And so you can also get reactive inflammatory changes in the testicle that might throw you off as far as your ultrasound. In my practice, we generally had a ultrasound tech readily available in the hospital or soon thereafter. In patients I thought had torsion, will go to the operating room, and those you're not sure, I'll actually take the patients to the ultrasound suite, meet the radiologist and the tech there, and just be there when you're doing the exam, because then if there's problems, you can facilitate things, And from a practical standpoint, we'll give our operating room a heads up that we potentially may be adding a case just to facilitate things. And I think we can get an ultrasound done within 20 to 30 minutes, probably about as fast as they get a room ready for me. So if we focus just on the diagnosis of torsion, as we talked about, so remember in time of puberty, after puberty, about 90% of these cases, so the majority, but not all, are going to occur after age 10. You will hear a description of trying to detorse the testicle. If you think about the direction that you want to twist in most patients, is that if you're standing at the foot of the bed and you open the book, so if you have a patient here looking at the left testicle, you would twist this way, away, and laterally. One of the issues with that, when you end up exploring enough of these patients, is that very uncommonly is it just one twist. It's usually a 360 or sometimes even up to 1080. I feel like a X Games announcer here. And so it can twist more than one time around. The problem is that on occasion you'll get an ER doctor that will say, well, I did manual detorsion and then we did an ultrasound, it looks fine. And so in my mind, that doesn't help me a whole lot. If I'm going to consider manual detorsion, I typically would do it in the setting of ultrasound having suspicion. If you manually detorse and then the ultrasound looks better, then the urgency at which you have to do something is decreased. But in that patient, you would still be suspicious of torsion. You'd still go to the operating room and then do a pexy or place some sutures to hold that testicle in place. So in patients that were suspicious, you go to the operating room, you expose the testicle and see if it appears viable. You untwist it, and then you look at it, see if it pinks up. You can nick the tunica albuginea, the white layer around the testicle, and see if it bleeds. You can use a Doppler ultrasound probe to verify that you have some blood flow. And then you can pexy the testicle if it looks reasonable. If not, you remove the testicle. If you look at the series, there's a population-based series that the chance of doing an orchiectomy at the time of exploration is about 25%. The majority of the testicles are able to be saved. If you look at the timing, there's a stepwise manner. If you look at some of these studies, it actually looks like their data is something you'd make up because it's very clearly tied to the amount of time. If you get these patients to the operating room within 6 hours, the chance of success with not removing the testicle is probably close to 100%. In that 6 to 24 hour period, it's in between. Greater than 24 hours is near 0%. But if you look at the small series that have evaluated those patients, they'll still tend to have one or two patients that still have viability. The other concerns is you have to follow these patients to see if they have atrophy of the testicle in the future. So move on to a different topic here in the ER, looking at ureteral stones, something we see very commonly. So we know stones are common. There is what's called the stone belt in the southeast part of the U.S. It's thought to be related potentially to things like diet and obesity. If you notice, my resident state there, Iowa, is actually an outlier, and we see a fair number of stones too. With the seasonal variation, we actually see more stones in the summer, thought to be related to dehydration. Anecdotally, back in 2008, I was at one of our community practice urology groups, and that was when the floods were, and they had a water supply that got knocked out, so everyone had to drink bottled water, and people clearly weren't drinking enough. There was just a massive amount of stones that came in and during that time. So in patients with stones, it's important to keep well hydrated. We'll also find stones potentially when looking at other sources of for causes for recurrent urinary tract infections, sometimes even large stones up in the kidney, big staghorn calculus. want to talk just a bit here about imaging, because this is important. If you look at, if I absolutely want to know if there's a stone there or not, clearly the CT scan, non-contrast abdomen pelvis, is going to be the study of choice. A near 100% sensitivity for stones. The only stones you wouldn't catch are very tiny, 1 or 2 millimeter, probably clinically insignificant stones that are in between the slices of the CT scan. If you look at, well, what if we try to limit the amount of radiation that we're giving patients? If you look at just a plain x-ray, about a 60% sensitivity for finding stones. Keep in mind what we usually talk about is that uric acid stones aren't seen on plain x-ray. Those make up about 20% of patients, versus calcium stones, struvite stones related to infection, or cystine stones you can typically or should be able to see on x-ray. So where do we go from that 80% to that 60% sensitivity? It's because of a combination of patient obesity making visualization more difficult and having overlying bowel gas that doesn't allow us to see things very well. And so if you're getting just a KUB, my notes will always say no radio-opaque, stone readily identified, but you can't make the justification saying no stone present. Ultrasound has been used in combination with KUB, has a sensitivity of about 60%, very high specificity. And so in select patients, you can clearly consider using ultrasound in combination with KUB. And when I was down as a fellow in St. Louis, they were working on a protocol in the ER. Patient initially presents with flank pain. They're randomized to either getting a CT scan or getting a KUB in combination with an ultrasound. The idea being that if you had a clean KUB and an ultrasound that showed no hydronephrosis, the chance that they have a clinically significant stone that requires intervention is going to be pretty low. One other thing that we will talk about is radiation exposure and trying to limit that, especially in patients that are recurrent stone formers. That radiation dose is measured in millisieverts, and so a plain x-ray is typically about 0.4 millisieverts. If we get an abdominal and pelvic film, then you're a little bit, double that, or just a little bit over 1. To put that in context, the general background amount is about 3 millisieverts a year. In the U.S. has actually been reported to be 6 millisieverts. And so it's not a huge dose with a plain x-ray. If you stepwise go up to a CT scan, that's closer to 10 millisieverts. And there's a very good website. I'll say it a couple times here because I didn't include it in my handout, but it's xrayrisk.com. That's xrayrisk.com. It's the American Society of Radiation Technologists. So you can actually really easily go in, you plug the patient age and the imaging modality, and they will give you a risk of secondary cancer from that study. So I actually will use that with patients. If you plug in, if I were to get a CT scan, the risk of a secondary cancer from that is about 1 in 935. So that sounds small. If you look on the website, they list different probabilities. The chance of dying of drowning is about that same percentage chance. But I still keep in mind, and when I talk to my residents, I'll tell them, well, it's like you're giving somebody a pill that gives them cancer, but just a little bit. And especially in recurrent stone formers, if they're getting recurrent imaging studies, that can add up over time. So it comes out to about 0.1% with any given CT scan. But as we'll talk about in a little bit, there's potentially some patients that if you make your decision point not do they have a stone or not, but do we need to do something about that stone or not, that changes the mentality for getting a CT scan. There's also some protocols that if people are actively involved with their ER department to consider low-dose CT scan. So you get a really crappy picture of the rest of the abdominal cavity, but stones are bright enough that you still get pretty reasonable stone evaluation. That has about 1/6 of the dose compared to a regular CT scan. I always tell our medical students, if you want to think about stone size, just keep in mind in general that a stone in the ureter, a stone of about 4 to 6 millimeters, is what I consider a moderate size. Stones that are smaller are going to be much more likely to pass. Stones that are larger will be less likely to pass. However, on occasion, you may get someone that passes, a 10, 12, even 15 millimeter stone. All that is fairly unusual. We had always taught our medical students, I think Dr. Winfield had taught me this back in the day, that the stones get hung up in 3 locations as the renal pelvis narrows to the ureter, as the ureter goes over the vessels, as it crosses at the common iliac artery, and then as it goes into the bladder. My understanding of this study, there was actually a medical student who said, "Is that really true?" So they looked at thousands of CT scans and said, "Well, that's not actually true." So so I expect some sort of refund from Dr. Winfield in my prior medical education. So actually the majority of stones, and this picture is clinical practice, the majority of stones actually will make it to distally until they present with problems. Very rarely, 1% of times, are vessels hung up on the iliac vessels. So a couple of very important points about stone management. So stones are common. People don't think a lot about stones sometimes, but I will talk with our residents that this is a potentially life-threatening diagnosis, and you need to consider that and counsel patients about that. Because of our system, we will sometimes see patients that are sent from 4 or 5 hours away, and they'll be told, "You have a stone, you go to the university, they'll treat you and get you out the next day." Not exactly true. What we are considering is what needs to be done acutely as far as do they need drainage of an obstructed system or not. We can do that with a ureteral stent from down below. We can do that with a nephrostomy tube put directly into the kidney from up above. The other choice about treatment, using a small scope and a very small laser, or shock wave, or putting a tube into the kidney and treating the stone that way, is typically not made in the acute setting unless the patient looks very, they're not. You have to make sure they're not infected and that you don't have any concerns about that. And so there are a few groups out there that may treat people on the same day, but typically uncommon. One of my concerns with treating patient on the same day is on occasion you'll get a stone that's pretty good as far as obstruction. You put a stent up. Their urine had been clear, but when you put the stent up, you just see a massive drainage of, basically frank pus coming out of the ureter. So your urinalysis in the, or culture in the setting of an obstructed stone is going to be pretty good at catching infection, but you could have a lot of infection behind a stone that you may not get an indicator for as far as from just a urinalysis. So most important thing to consider is fever. The second most important thing to consider is fever. And so also consideration of elevated white count. The most important thing I teach our medical students, I think, is if you have a kidney infection you treat with antibiotics, people get better. If you have just an obstructed stone without infection, people have pain, but nobody has ever died of just kidney stone pain, even though it can be very severe. If you guys are ever bored, you can Google our YouTube videos on stones. If anyone watches Modern Family, there's a video that they were right on, and one of the male characters had a stone. But those people tend not to get very sick. If you have a combination of infection plus obstruction, those people sometimes will get very, very sick. I have heard of a patient dying from a distal 2 millimeter ureter stone because he sat at home, for several days with fevers and chills. He came in with a creatinine of 5 or 6 and multi-system organ failure. So you want to keep that in mind when you're sending these patients home and counseling them, even if they just have a tiny little ureter stone. And so the other scenario to think about, since you guys are in general medical practice, probably once or twice a year I get a consult from our ICU. Patient's been admitted and they'll say, 3 or 4 days with pyelonephritis and they haven't gotten better. And so before they finish that sentence, we ask them if they've gotten a CT scan to look for a stone. And relatively surprisingly, oftentimes they haven't. And so I've seen several patients with that, typically 1 or 2 a year, that if you have a patient who has pyelonephritis, if it was my family member or my wife, I would want some sort of imaging study to be done. You could definitely consider just an ultrasound. I oftentimes will get a CT scan because I want to be very sure, but I think that's another big take-home message that in my mind, the idea of calling something uncomplicated pyelonephritis is a little scary because you don't really know unless you have some imaging study. So other considerations for drainage, if a patient's in absolute pain and that's not controlled, We'll use things like Toradol in the ICU, or if we admit a patient, consider other things like hydrocodone or stronger pain medications to try to get their pain under control. Classic teaching, it's not the stone itself that causes the pain, it's the distension of the renal capsule. I'll tell every patient, I can cut on your kidney with a knife, you wouldn't have pain, but if you distend the capsule, that's where you get the pain from. And we'll talk about why that's important as far as follow-up in a little bit. If someone's having nausea and vomiting, they're going to be very unlikely to be able to keep down pain medications. They have a very high bounce back rate, and so those patients will consider intervening sooner. If you have a patient with a solitary kidney, clearly that's more of an emergency. The typical patient who comes in with a stone, their creatinine may be 1.6 or 1.7. The ER sometimes will call and say, oh, this patient's got some renal failure. Most commonly, that's just an element of dehydration, because when we admit the patients and hydrate them, typically that will get better. And so the kidney is pretty tolerant to obstruction, but just to keep in mind, I won't absolutely stent someone just based on creatinine unless it's much higher. And that patient, I'm actually more concerned about urosepsis and multisystem organ failure than I am just that their stone's causing a mechanical obstruction. We don't decide just based on size whether to stent someone. However, if their stone's pretty good size, 10, 15 millimeters in the ureter, they're probably going to be less likely to pass that. I don't care if there's hydro or not. Except in the patient that has a ureteral stone and no hydro, then you question, is that stone really causing their source of their pain? Actually been studies looked at perinephric fluid. If you get buildup of urine obstruction, you can pop a fornix and have some urine leak around the kidney. That doesn't seem to be associated with the chance of passing stones, and we actually don't typically use that as a decision point in whether we should do something about the stone or not. Another important take-home message, what can we do to help people? This is how many people here have used alpha blockers for stones? Yeah. So it's starting to catch up speed, and RER is pretty in tune with this now. They'll send everybody on an alpha blocker. So if we look at what's the chance in general of passing a stone, the biggest study from Miller in 99, that percentage was 83% chance that they'll pass the stone. 95% of people passed it by 6 weeks. There's been studies looking at calcium channel blockers, steroids, alpha blockers in helping people pass stones. And the alpha blockers have the most evidence. There's about 15 randomized trials, so you have level 1 evidence about this. If you look at their stone passage rate, the likelihood ratio increases by about 44%. So if you have someone who has 83% chance of passing a stone, that goes up to about 91% with the alpha blockers. From a practical standpoint, tamsulosin doesn't require dose titration and has less orthostatic symptoms, so I typically will do that. You want to write on your script, especially in a female patient, for medical expulsive therapy. Otherwise, the pharmacist will call you and wake you up in the middle of the night and wonder why you're putting a woman on an alpha blocker. And so then I typically will give them 4 to 6 weeks worth of alpha blocker and then have a follow-up at a couple of weeks and tell them that if they have problems in the interval to let me know. The most important part of my counseling is if you have a fever, I absolutely want to know about that, and you're going to get a stent because you don't want to be on the wrong side of that. The other thing about counseling is the ER will classically tell someone, if you have pain, come back to the ER. So that's absolutely wrong, because what I want people to know is if you have pain that is uncontrolled and you can't tolerate, then come back to the ER. I'll draw them a little picture and say, your kidney has to build up pressure. You have to have more pain to pass this stone. So that's just a lesson learned from having people maybe bounce back to the ER too soon when they don't need to. One thing as far as radiation exposure, you can look on the scalp film of the CT scan if you have one and see if you can visualize the stone. If not, please get a KUB to see if you can see the stone, because if you can, then when they see your friendly urologist in a couple of weeks, they can just get a plain x-ray and evaluate if that stone has moved in the interval, if it's passed. If they haven't had a plain x-ray, and then it becomes very difficult in clinic to figure out if they passed the stone or not if they haven't captured it. So then the friendly urologist sometimes becomes less friendly and has to, then get a CT scan, which isn't going to be in the best interest of the patient. Some of these patients may need CTs with follow-up, but we can try to limit that. So that's a very important thing that I think all of our residents know to pass on to the ER if they get called about a stone. So now, briefly, just to touch on priapism. So that is Priapus, the Greek god of fertility and horticulture. And so priapism, an erection lasting longer than 4 hours, again, common theme. Delayed management has problems, potentially a lifelong risk of erectile dysfunction. Two main forms of priapism. The most common type, the type you should know, is low flow or ischemic. The type you can probably not think about much because I've seen maybe 2 or 3 cases in 10 years is high flow. That's much rarer. It's associated with trauma, and you get sometimes an arteriovenous malformation. The cavernosa of the penis are actually still well perfused. It's just that they're overly perfused. So it's not ischemic. They typically do not have pain. It is not treated as an emergency and typically is managed by interventional radiology with selective embolism during the day, and then can be treated by a selective embolism, as I mentioned there. In contrast, low-flow ischemic priapism tends to have pain. So you can differentiate those two very clearly by doing an arterial blood gas of the penis. How many people have done that? No? Okay. 3 of us, only 3. And so, actually not hard to do. I'll explain how to do that. How do you know one from the other? Ischemic will result in a very frantic phone call from your lab because all of the values that you get are not consistent with life. So very low acidotic, I learned that. And so acidotic pH, very hypoxic, very hypercarbic. Why is that? It's basically a compartment syndrome. My brother is a orthopedic surgeon, so he knows more about that process than I do. But you have basically no outflow, and then you have no blood flow. With no blood flow, things die. We're just simple plumbers as urologists. So if you don't have blood flow, things will die. And so you have to think about how you get that drained. Things that cause this. So trazodone is probably the most common. And we have to, if Dr. Griebling's still here, we have to match his stats. So the reason for that is it's also an alpha blocker and a serotonin blocker, and the combination of those, for whatever reason, results in potentially patients getting priapism. One of the issues is trazodone is very, very commonly used, even though the risk of priapism is low because the denominator is so large. That's what results in these being the most frequent, probably prescribed medication. Some of the other antipsychotic, antidepressants you can see it with. I've even seen this in young kids on multiple agents for ADHD. Alpha blockers should have the same mechanism as priapism, and we should see it, but we very, very infrequently see it with alpha blockers. If you watch a golf tournament on the weekend and any commercials for any of the available agents, like Levitra, Cialis, Viagra, you will get mention of priapism. But more interestingly is that the studies that have been done, the largest study was done by Morales with Viagra, over 4,000 patients, and 2,000 of those patients were followed for a year, had no reported cases of priapism. I, in my practice, have never seen prescribed use cause priapism, occasionally recreational use. And so very, very uncommon. I half the time now I guess I always tell my patients about the risk, but it's pretty uncommon. Penile injection therapy for erectile dysfunction, the risk is about 1 to 5%, but the denominator is pretty low, so we don't see a ton of those patients. Drugs of abuse is probably the absolute most common. Sickle cell, you get some sloughing of the red blood cells. They cause problems with the venous outflow. I did a month down in Dallas where they had a bigger sickle cell population, and they probably saw 1 or 2 of these kids per year. Classically, the teaching had been hydration and oxygenation, but the reality of it is that those kids were treated with injection therapy, as we'll talk about in a little bit. Very rare cases of malignancy causing it. So the primary care doc will usually get, CBC, coags, toxicology screen if African American, then consider whatever the appropriate evaluation for sickle cell is. An arterial blood gas, which we talked about, very rarely is ultrasound used. So the treatment is corporal aspiration and irrigation. So I actually will, at one point, emailed this to myself, and then if I get called into the ER, I say, oh, just a second, I'll have to call you back. I pull it up on my email, then I read them exactly what I say here. So phenylephrine comes in a ampule, one little bottle. If you dilute that in that concentration, it gives you 250 micrograms of this per milliliter. You don't have to do the math. I did it for you there. Then you get a needle and a syringe and a stopcock and some tubing. Then you can do an arterial blood gas. I'll show you the picture in a second. And some sterile stuff to do that with. And you want to make sure that your concentration is correct. I looked, in preparation for this, was Googling some stuff about this. There was an ER video that clearly had the wrong concentration and would have resulted in too much medication delivered. So if you overdose someone, they could get headaches, very, very high blood pressure. And so you don't want to do that. And I typically will just slap on a blood pressure cuff in the patient. So this is very easy to do. You do not want to go at 12 o'clock because that's where the dorsal vein is. You do not want to go at 6 o'clock because that's where the urethra is. If you go anywhere from here to here, you're fine. The corpora communicate with each other. Interestingly, with priapism, the corpus cavernosum here are the two larger erectile bodies should be firm, but typically the spongiosum is not. And so what you do is you poke a needle in. I oftentimes won't even do a penile block because they're in enough pain and it's just one needle poke. You want to use a pretty reasonable size like 18-gauge angiographic catheter, and then you can suck blood out, send it for a blood gas, suck blood out basically to relieve that pressure. And then you can flush in with saline and then suck blood out again. And sometimes you can suck out, increments of 60, 50 cc's times 4, 5, 6 syringes to try to get the blood flow working again. Typically, by the time I see the patient, the residents have been unsuccessful with that, and then we'll instruct them to do phenylephrine. So that 250 micrograms that we talked about per cc, you just inject 2 of those cc's, and then you wait for 3 to 5 minutes, and then you can repeat again. You can do that for up to an hour. The reason I went into academic medicine was so I could have residents, because this becomes super awkward after about 15 minutes. And so if that doesn't work, you can then we'll take them to the operating room is the gist. Because it's before lunchtime, I excluded the pictures because they become kind of graphic. But basically, you're sticking a scalpel into the head of the penis. The glans is very close to the tips of the corpus cavernosum. And so if you stick your needle, or your syringe, the bigger syringe, and you plunk into this corpus cavernosum, and then you rotate about 90 degrees laterally, you'll make a shunt there. And in cases, we even put a sound down to open that shunt. And you're trying to shunt that blood flow out so you reestablish your outflow. We always tell these people about potential risk of erectile dysfunction, but there's some larger series now with these shunt procedures that it's actually pretty reasonable. And sometimes we'll even work out at 1, 2, 3 days after initial presentation. Patients that don't work, you have to do a proximal shunt, and in rare cases, we actually will offer them a penile prosthesis if it's been long enough. So I'll skip the second case, but one quick case just to make a point. This was during my intern year. There's a 3-year-old boy. He woke from a nap in pain, complained of a stomach ache, no fever, no known trauma, but then he was having a lot of scrotal pain. They lived in Iowa City, so they came immediately to the pediatrics clinic, no fever, but he had a very swollen, tender left testicle there, pretty hard to examine, with some swelling into the inguinal region. His timing was perfect in the day that he actually was evaluated by a pediatric surgeon and a pediatric urologist. at the same time point. We thought about all those things. We both, with my 6 months of experience and their fellowship-trained experience, everyone thought we should take the patient to the operating room. Turns out we explored the patient, and he just had some exudate on his epididymitis, and it was just epididymitis. Exudate on his epididymis, so it's just epididymitis. So the point there being that that you're not always going to be right, but that's the right decision, not the wrong decision. In hindsight, we'd sent a urine, but I don't think anyone had really looked at it too close, and it ended up growing bacteria. It ended up having a urinary tract infection. Got treated, but that's a case that was presented at our M&M, but isn't really an M&M. So there's my kids in my backyard. All right, do we have our questions?
Are there any questions from the audience? Yes, sir.
When I saw in the pediatric population, so the adults, and forgive me if I'm asking you, but would you ever see non-acute portion, meaning gradual development, and so along the duration?
So in all of urology, we see a lot of ball pain and or calcia, and a lot of these patients. And I don't think anyone really knows. There's a big multi-center trial looking at interstitial cystitis in women and bladder pain and pelvic pain syndromes. There's some talk of prostatitis and chronic pelvic pain. We clearly see some of these patients as adults who have orcalgia. My typical regimen is to, if you see them acutely, to examine them. If they have real severe pain, then you're going to get an ultrasound on those patients. On rare occasion, if it's real concerning, then you might take that patient to the operating room. But most of them will have an absolutely normal ultrasound and actually will have the finding of increased blood flow to the testicle and the epididymitis and to the epididymis, which is consistent with epididymal orchitis. They'll get a course of antibiotics, even though a lot of times their cultures will be negative. And then they will continue to have some pain that comes and goes. One of my chairman, he was in the military, and he would see this all the time at military bases. Anecdotally, what he talked about is telling people to try to avoid, any lifting whatsoever. They would almost put people on bed rest in the acute setting, and then, anti-inflammatory pain medication. I've seen a couple of these that didn't look too bad, then progressed to an abscess. So then what will happen is I think they get their nerves turned on and it becomes sort of a neuropathic pain, because then you'll see them down the road. They'll still have some pain. I typically will repeat an ultrasound at some point just from a medical legal standpoint to identify that they don't have a small mass. And then they'll work their way amongst primary care providers, different urologists, until at some point their pain gets better. And so, you could postulate, could they be having intermittent pain? When you talk to most of these people, they have more of a chronic, ongoing pain than a real severe, sudden, spastic type of pain. And then there's also, in those patients, sometimes denervation. But so we do see those patients sometimes. All right, do we have maybe we'll do the response questions and do that. And I'll be available afterwards as long as people have questions also. Do our audience response again. So what is the most common cause of acute scrotal pain in the pediatric population? This is based on clinical presentation. So it actually depends on how you answer or ask the question. So if you look at studies, if pain is less than 6 hours, then torsion's right. If it's a longer period of time or all-comer, mitis is right.
I have our next question. Which of the following is the least important reason to seek urologic consultation for a ureteral stone? So
I think the two debatable ones are probably large stone or perinephric fluid, but in my mind, I don't worry about the perinephric fluid too much. That's been supported by some of the retrospective literature.
Is it all right if we name it Angie? Well, that might happen.
This is how when I operate now, I hear that voice sometimes in the background.
Saying, did I say something?
What medication results in the most trips to emergency room for priapism? All right, so we're not as good as Dr. Griebling, but I would agree with trazodone. And the main reason there's just so many more people that are taking trazodone than there are that are on injection therapies.